Good morning, everyone, and welcome to today's webinar, A Dynamic Method for Tracking Implementation Strategies and Modification, the Longitudinal Implementation Strategies Tracking System, or LISTS. My name is Eduardo Salinas, and for those of you that don't know me, I'm the Communications Coordinator for ISKI. We're very excited for today's webinar and for Dr. Smith to present. And I do want to remind everyone that we do have the Q&A function at the bottom. If you wish to pose any questions throughout the webinar, we will have time for those at the end. Now, I want to introduce our presenter, Dr. J.D. Smith. J.D. Smith is an associate professor in the Department of Population Health Sciences, Division of Health System Innovation and Research at the Spencer Fox Eccles School of Medicine at the University of Utah. He serves on a number of national committees and advisory panels on implementation science and is currently the associate editor of the journals Prevention Science and Family Systems and Health. Prior to joining the University of Utah in fall 2020, Dr. Smith was an associate professor in the Feinberg School of Medicine at Northwestern University in Chicago from 2015 to 2020, where he served as the associate director of the NIDA-founded Center for Prevention Implementation Methodology for Drug Abuse and HIV, and co-director of the program in Dissemination and Implementation Science in the CTSA. So thank you, Dr. Smith, so much for being here with us today, and I will now hand it off to you.
Florida, really nice to be able to share this work with you all. Please feel free to use the chat or Q&A functions. I'm going to keep them open on my desktop and hopefully not get too distracted, but yeah, this can be interactive. I don't have, tight time on this one, so we can take some clarifying questions and things kind of midstream. But I'll go ahead and just jump in so we make sure we have time for Q&A and whatnot. So a lot of this goes without saying, but one of the impetus for actually creating this tool is that within implementation research, there is a need to comprehensively track and report many of the implementation strategies that we use. And this can be really important for experimental designs where consistency or difference between within and between units and implementation studies is really kind of critical. One of the things that's been a challenge so far is that we don't really have a lot of systematic approaches for tracking dynamic changes in particular and how things change over time. We've had well-established reporting strategies or reporting and specification approaches, but not necessarily, kind of tracking these dynamic changes. There are papers that are published, and I kind of have these here below to show how people have used different sources of data. So Bunger Powell et al. In 2017, they used activity logs of implementers to track strategy use. This was done retrospectively, essentially. Any kind of retrospective is going to have some limitations in terms of availability of data, whether or not you have the right frequency and the right information to really capture all the pieces you need. Boyd, Powell, Endicott, and Lewis, they coded meeting transcripts. So a similar approach of existing data source went back retrospectively and coded how strategies were being used. Russ Glasgow and colleagues conducted semi-structured interviews. So this was actually a prospective method where they had multiple meetings in 6-month intervals to interview the implementers and the project teams about their strategy use and how things had changed in that previous 6-month period. Not surprisingly, REAIM was used as a way to really understand some of the reasons for those and conceptualize it. And then last year, Haley, Powell et al. Actually compared 3 different types of kind of data availability and how well you could use those for tracking strategies. One of them was a purely brainstorming exercise. They also used activity logs and then also used detailed tracking logs. So this was kind of an attempt to get at what is the level of necessary data to really understand and be able to say something definitively about strategy changes over time. There's also one paper that is kind of relevant to how the LIST system was developed. Perry and colleagues using AHRQ funded studies did a synthesis of strategy use across projects within a consortium. And so this was done completely post hoc, again, kind of using data that was already collected or actually just asking those different sites about their strategy use to look for consistencies and synthesis across the projects. So the objectives in creating the LIST system was having a system that would allow for capturing dynamic changes, including planned and unplanned strategy modifications. So basically meaning things that were decided a priori. We're going to, introduce new strategies. We're going to discontinue strategies at certain phases of projects, things along those lines. But also unplanned, so things that changed as a result of maybe implementers doing something that wasn't part of the protocol, so completely unexpected, maybe even considered like a protocol deviation. Or unplanned modifications that were due to things like emergent barriers, confounding variable effects, and other events like the pandemic that you wouldn't have been able to have a priori. This also was going to try to capture additions and discontinuations of strategies, and again, whether or not that's planned, unplanned. We also wanted to be able to produce data that could be compared and synthesized. So providing a structured enough reporting system that you could pull across similar kinds of projects. And again, this was because this came out of a consortium that I'll talk about here a little later, that this was kind of one of the main objectives, but this is clearly something that's important for all of implementation research, is to be able to synthesize our findings. So today I'm going to describe a few different things. So I'm going to talk about the longitudinal implementation strategy tracking system, of course, really focusing on the administration procedures, as well as introducing our electronic data capture interface that is programmed in REDCap and available for download. I'm also going to present some data on the usability and acceptability of lists, as well as some things that people liked and didn't like, or things that they found challenging, essentially, in using the tool. So just kind of thinking about what is actually included in lists, we wanted to use kind of existing reporting standards and guidelines. And so we picked the Proctor Powell and Macmillan 2013 strategy reporting and specification standards. Within this, they have you name the strategy, and they specifically said, try to use existing language. Well, at the time in 2013, the Powell et al. 2015 ERIC taxonomy was not out, but now that it is, that is what we used for our naming convention. And so people are asked to categorize all of their strategies within a specific ERIC taxonomy code, and then operationally define them so that it's clear exactly how those strategies are being used or how they're being described. For each of the strategies too, specification involves the actor, so who actually is involved in using the strategy, what actions do they perform, what are the action targets, like who are they trying to change, what are they trying to change. This can get into outcomes or could get into audiences, etc. The temporality of the strategy use, this is really kind of over what time period. And then the dose is the kind of frequency of use and the amount of minutes that it requires to do the strategy each time it is used. We also had people using the RE-AIM and Proctor frameworks for implementation outcomes. We asked people to specify what is the primary and secondary implementation outcome that this strategy is hypothesized to be directly trying to change. So if you knew that, if this was to work, how would you know what implementation strategy or what implementation outcomes would change? One thing that we added that was not part of the Proctor et al. 2013 standards is we asked people also to say which barriers are being addressed by the strategy, and we use the consolidated framework for implementation research. You're allowed to pick multiple barriers, but really it's kind of which ones do you think are the most prominent? Conceptually, why did you actually choose to use this strategy in the first place? So some additional elements that are obviously beyond specification is classification of modifications or adaptations to the strategies that are being used. And this is sort of kind of on the per strategy level, not kind of the project level, which we can talk about the difference here in a little bit. We use the FRAME-IS, which is the framework for adaptations and modifications for implementation strategies. The IS is the strategy extension to the original frame. So what happens is anytime that a strategy is indicated as having been adapted or modified, it introduces branching logic within the REDCap that prompts questions concerning the reason that this modification occurred. Some examples that we have, these are forced choice, or at least options that you can select. Is that there was evidence that it was ineffective, evidence that it was infeasible, and so it was discontinued or it was modified to become more feasible. We also ask who was involved in the decision, and this is very relevant if you're talking about unplanned or planned. So for unplanned, it's really important to know who was the person who did something that was kind of not part of protocol versus those things that might have been prospective and part of the research team. Also kind of the per protocol again, planned or unplanned modification. The one thing that's different that is not part of the FrameIS, because FrameIS was really kind of like under the assumption that a strategy is being done, therefore it can be modified, and we need to classify those modifications. But in a dynamic perspective, you can at a project level add strategies, of course, that were not part of the original protocol or actually were planned as part of a protocol change or just kind of the introduction of strategies as it's appropriate. So in this particular situation, when you add a strategy in the list tool, it again gives you a number of kind of branching logic questions. It asks about the reason that this was added, whether it was used to address an emergent barrier, to complement or supplement other strategies, to increase effectiveness, or purely because it was just part of the a priori protocol. You have the planned and unplanned again, as well as when you're adding a strategy, it bumps you back to the previous screen where you have to do all the specification of the strategy as well. So here's a little sneak peek. This is actually available. I haven't updated my slides, unfortunately. This is available through a download on GitHub. And all of the aspects of it are part of kind of standard REDCap. And so every university should be okay to download and activate the LIST program within your REDCap instance. So here's just a snapshot of kind of what this looks like. So you can see number 3 is what implementation outcome are the primary targets of the strategy. You can check all that apply. Was this strategy prospective? And you can see here I have an example to say, no, this was not a prospective strategy. So it adds these additional questions about number 5, number 6, to specify what was going on to add the strategy. Like why was it introduced when it was not an a priori strategy? So in this case, we had selected to augment the effectiveness of another strategy. And then I haven't mentioned yet, there is a kind of a personalization feature that has to do with the number of units that are in the study. And so I'll talk about that here on the very next slide. Yeah, response to Gabriella, yes, I'm happy to make the slides available. And I think that the recording will also be made available on the ISKI website. So project customization. So when you're setting up a REDCap project for lists, every project has the capacity to specify the kind of appropriate clinical units or study-based units that are involved. I have an example here from the project that we used to test this out, which was these are 7 different clinical units that are naturally occurring within Northwestern medicine, where this project took place. And so we actually have a randomized rollout implementation design where each of these units starts at a different time point. So that in that way, these become meaningful units because, in that kind of a study design, you'd want to know whether or not there was differences in the implementation used across the different the clinical units that are involved in the study. So how do you actually do this? So you actually are allowed to specify and name the strategy or name the units. You can have as many as you need or want, and you could use lots of different levels. In this particular case, these are clusters. These are clusters of kind of different clinical practices or different clinic locations, as well as obviously lots of implementing physicians and nurses, et cetera, within each of those clinics. You could actually get down to the implementer level if your implementation strategy focus is really on changing individual provider behavior, for example, or clinician behavior. You could actually name specific clinicians. But this is really kind of dependent on what is the meaningful study unit for your particular design. So again, you want to align with the study design, potentially the level of randomization, the level of the appropriate or most prominent strategy, and obviously outcome. And then there is kind of a question too about the level of research or degree of granularity that's important for your research question. And we can talk about this here in a little bit too about, why would you want to do this level of detail in certain studies? What are kind of the indications for that? But again, if we even wanted to do within this example here, we have 7 clinical units that have multiple clinics within each one. we did not differentiate those individual clinics because it's really the cluster unit that was most meaningful in this project. For usability, the other thing that we have, you can see at the top here, is we have this kind of quick button where you can just say it is across all units in the study. Therefore, you don't have to specify anything. If you click on the across specific units, then you get this drop-down menu that basically says, okay, check the ones that it applies to. And this allows you to say, like, strategies are being used differently in different units, or maybe a strategy is not being used at all in certain units. So you'd want to indicate those differences. But those, the across all units is really meant to just save you the hassle of having to click through all of those available units there. The other thing that's kind of cool about the REDCap program is it also kind of serves as a bit of a dashboard. So every time when you actually get all of your implementation strategies entered, you log into REDCap, this is not a survey. It is actually more of just a database. And so you're going to be able to see all of the strategies that you've entered. There is also going to be color coding that says basically what the status of this particular strategy is. And really what's most important is this one was done. It's no longer in use, or it's currently in use. This becomes relevant because as you go through doing modifications and updates, you're probably not paying attention at all anymore to the ones that have been discontinued. It really is the ones that are active that matter. So it helps really kind of hone your focus on the strategies that actually might need attention. But the cool thing is because it's not a survey, it really is a database. When you go back in at predetermined intervals that I'll talk about in a moment, there's no need to re-enter anything. All the strategies appear. You only have to make a change or do anything with a strategy if a modification has happened. So there might be situations where you actually meet with your team to discuss modifications. No modification's been made. Nothing needs to happen in REDCap. So some of the methodology for using lists. So the actual development of lists was an iterative process between implementation researchers and practitioners. It included feedback on an initial set of questions, response options, frequency at which we should actually, kind of revisit the list tool in the database to think about those dynamic changes. And then also what kind of data capture method would be used. So of course we did decide to go with REDCap. So list completion, the people who need to be involved in completing lists, we want it to be completed by research team members and local implementers. However, for various reasons, we give guidance that really each project should have one REDCap. So there's no reason to have individual people actually keeping their own databases. It's a project level database. And because of that, you end up having to assign usually one project coordinator, one investigator, or somebody like that on the team that is responsible for the actual entries within REDCap and the updates. But meetings involve other people who are going to know what is actually happening on the ground, as well as implementation scientists who can help actually interpret some of the actual data. I don't know what happened to my screen. I'm going to stop share and reshare. Okay. I still don't know what happened. Are you guys seeing? Okay. Sorry. Okay. So the procedure that we're proposing to use that has worked really well is a timeline follow back procedure. So this really gets away from the retrospection error that happens when there's long periods in between reporting or at least reevaluating strategy modifications. So depending on the stage of research of the project and potentially the research design itself, the actual interval between kind of lists meetings can vary. The recommendation that we have is between 1 and 3 months. Lists needs to be kind of revisited to evaluate whether things have changed. If you're using a study design where things happen very rapidly, maybe there's an attempt actually to optimize or change things over time, and that is actually part of the a priori design, you may want to meet more frequently versus a study that changes are not happening at nearly the same kind of frequency or are less likely to occur. So that could be quarterly kinds of meetings instead. In this particular case, the research centers that were involved in the development were provided with a procedures manual, but they were explicitly given some flexibility to determine the most efficient means of using the list tool while maintaining the goals of the method. And that was to help us figure out exactly what kind of guidance to give you all in actually adopting this tool. And so the data that I'll actually share and the usability results that I'll share as well were actually based on 15 months of using the list tool. And kind of importantly, this started in year 2 of the project periods. So it required a lot of kind of reporting of things that were already in practice, or even things that had been used but were already discontinued. And that is not the way that we want lists to be used in the future. We'd like it to be really we want it to be fully prospective. But knowing that you can actually jump into a project kind of midstream can be kind of helpful. You just lose some of the benefits of the timeline follow back procedure, of course, because you're basically reporting a lot of data, much more than 3-month intervals at one point. So we evaluated the list tool across 3 different research centers that are all part of a similar consortium. We looked at the procedures they used, the dates of their use, so actually looking at objective data, the time involved, and who was involved across each of the different research centers. We also asked them about what kind of data validation methods they used. So things that came up were things like reviews of notes and team and project agendas, calendar entries, as well as asking on-the-ground staff exactly what they had been doing or how long these strategies were taking, et cetera. We also administered the system usability scale, which is really mostly about the REDCap tool itself and how well that functioned. It's got some interesting functionality, and you'll see from the comments as well. We also asked them about the difficulty reporting specific elements of lists, so some of the reporting items, and I'll talk about those here in a minute too. So basically, very easy to very difficult to feel confident in the reliability or even to know what this data element was. And then we asked open-ended questions about feedback, the things that users liked and disliked. Okay, so Bianca has a question. Given your emphasis on this being a tool for use by researchers, you would not view this as a tool that could be used by implementers reporting prospectively their implementation practice. You could potentially do that. I think you'll see from all the elements that are involved that it's a lot to ask of an implementer who's not compensated and not part of the research team. If they are compensated and part of the research team, totally appropriate to have them involved. But I think it's really hard for various reasons to rely on implementing partners. And you'll see some of the comments that might lead to that. But let's continue to talk about that. Yeah, hopefully it becomes a little bit more clear. So the actual procedures too, because this started kind of in 2 years into a 5-year project, that it kind of made us think a little bit about 2 different stages of using lists. And this is applicable to every project. It was just kind of more, I guess, underscored in this project since we started kind of later than would be intended if you were doing this prospectively. So we split it into kind of the process of populating the list tool. And this is really entering strategies that are already in use or have already ended and have been used. What we did to help people kind of jog their memories is we asked people to review the full list of ERIC discrete strategies to identify those that were in use or had been used at any point during the project. Because we were kind of jogging people's memory on that and making them think, basically, here's a strategy, did we use that? It led to a lot of strategies being entered, which is not a bad thing because it really does help us really understand the full picture of what's happening in a project. In most situations, people entered the strategies into the Excel spreadsheet that is the back end of the REDCap tool. So immediately people, once they specified their study unit, set up their project, they exported a blank Excel spreadsheet so that they could actually fill in all of the necessary elements and components kind of outside of REDCap itself, and then only enter it into the database once it was kind of finalized. One of the reasons this was important is that a number of the elements were not always readily available. So especially like the dose and the temporality, that often had to get additional data validation and asking other people about those elements before they could feel like they were final. And so having the Excel spreadsheet really helped kind of just keep track of what data elements were still needed from the team. We also asked people to routinely confirm the list elements. So asking other team members, looking back at calendars and meeting notes for like who was involved, when did this actually happen, what did we do in certain meetings. And we also had team leads or unit leads actually sign off. So it was not a formal sign off procedure, but we essentially said, hey, this is how we're describing the strategy. Can you tell us this is actually exactly how it was done within your setting? So that was kind of another kind of data validation point. And again, I already mentioned that we had a point person for compiling and entering the strategies into REDCap so that it was consistent within the project. Once all of the strategies that are kind of being used are entered, you can then start actually doing the updating of lists. So this is really the process of modifications, additions, and discontinuations. This required kind of routine check-ins with implementers to inquire about changes to strategies that were being used, or ask them if they've actually introduced new strategies as a result of their ongoing implementation efforts. Two of the research centers also did routine review of the entered strategies to assess for changes. So again, going back to that REDCap dashboard, looking at all those that are green, so they're still in use, asking people, has this changed from how it's described currently, and providing that data to them, and then making updates as necessary. One of the research centers, and this was one that had multiple health systems involved, so it wasn't as centralized as the others. They had periodic emails from the implementers, or they asked for emails from the implementers when changes and new strategies were being used or made. And those were then kind of triggered a process of updating lists for that specific research center. Another place that happened, and this was really kind of a product of using a stepped wedge or randomized rollout design, one of the RCs updated the list tool every time that a new study unit rolled into the trial design. And that was really important for various reasons, but really kind of to ensure there was consistency in implementation across the study units. So some of the results that I just want to share. So the initial population of strategies, we split this up into the amount of time that had been involved over this 15-month period. So Research Center 1, it took 6 hours, but 8 total meetings to get all of the strategies kind of entered that had already been used or were currently in use. They then had 7 additional meetings. So if you think about, this was about monthly, maybe a little bit less. They had additional 12 hours of kind of revisiting the list tool for doing updates and specifying modifications. Research Center 2 was a little bit different in how their time was spent. They spent 10 hours over 7 total meetings actually populating the list tool, and then only an hour split over 3 meetings to do updating. And I can say the reason for that is that this was a very centralized implementation approach that was kind of a top-down. And so there wasn't a lot of changes and modifications happening because it was such a kind of prescribed protocol that they had a lot of control over what was done within this particular site. The last RC is a little bit of a weird one. So this research center actually has 6 healthcare systems involved, where the other 2 have 1 healthcare system. So they spent a lot more time. They spent 21 hours populating the strategy tracker, and then they spent 42 hours updating. This is kind of a high estimate, and partially because they basically integrated the lists tool reporting and updating into monthly implementation meetings with each of the sites. So admittedly, they said it was kind of an overestimation, but they talked about implementation during all of these meetings. When additions and modifications happened, they would then trigger kind of list entries. But if not, nothing really happened. But these meetings were used to really kind of understand that process and gather that information when it was necessary. So some other interesting findings, just to share kind of what we found across these 3 research centers. So for RC1 and RC2, these are the ones that have one healthcare system involved. The majority of the strategies were prospective. So not a lot of things were kind of added that weren't part of what was planned initially. For RC3, most of the strategies were not prospective. And I think in large part, this was because their prospective strategy was very, it was a very small number of discrete strategies. And because of the diversity of the 6 healthcare systems, they allowed a lot of additional strategies to be used if necessary to kind of implement. So it was really kind of a product, I think, of how the study was designed and also the number of health systems involved. In terms of the location of the different changes or the use of strategies, RC1, again, one of the centralized research centers, was more likely to report the strategy was used across all units. They had a lot of power to be able to do that. RC2 and RC3 were more likely to report strategy use that was specific to particular units. And that was, in large part because of the 6 healthcare systems, but in the other one, it was because some of the clinical units are quite different. So that there's good explanations for why this happened. This is just kind of interesting things. In terms of who was actually doing the strategy, you can see there that a lot of it was done by the research study staff, whereas one of the projects employed their quality improvement leaders within the health system to do a lot of the actual implementation strategy use. Yeah, so I'm going to skip. This is actually just looking at different strategy categories from the ERIC compilation. And we have a couple highlighted that are kind of most used either by a single center or by all the centers. And so the use of evaluative and iterative strategies, very common across all of them. Developing stakeholder interrelationships and training and educating the stakeholders was also kind of highly used. In terms of discontinuations and stoppages, the vast majority of kind of modifications or updates to lists were because of planned stoppages. These were implementation strategies that were relevant maybe in the implementation preparation or early in implementation, but really were not relevant later in the project. So they were intentionally and prospectively planned to have stopped. You can see too that there was a couple of modifications that was because it was just kind of too many resources and realized that this was not going to be something that was sustainable. Or in the case of RC3 as well, a number of strategies were simply too time intensive. And so the healthcare systems decided not to continue with them. In terms of the usability and acceptability, using the system usability scale, we achieved an average score of 67.5. Keep in mind, this is only across 3 research centers because it was done at a RC level, not each individual person, since really only one person was doing the REDCap data entry. And the interpretation of this is that it's basically a C grade. The usability is okay, but there are areas for improvement. So that is part of our kind of next iterations of the REDCap tool. In terms of what was rated as most difficult, I don't think it's going to surprise anyone that the frequency of strategy use, which is basically the number of times or the interval at which it's used, as well as the amount of time that it requires for each use of the strategy, were the 2 most difficult. These are the ones that required the most communication with on-the-ground implementers, the most kind of data validation, and then also had kind of the lowest kind of confidence, I guess, that the actual thing that was entered was 100% accurate. Allison, I will get to your question in a sec. So let's just leave it up, but I will get to it in a sec. I think one of the next couple of slides is going to help address your question. So for user feedback, some of the aspects that users liked, I think the general consensus was that tracking strategies is really compelling and could advance the field. There's a recognition that implementation science is really almost entirely about implementation strategies, and we don't do a great job of tracking them the way that we should. People really like the structure, format, and functionality of the REDCap form. One of the quotes was, it does things that it has functionalities that I didn't even know existed in REDCap, which is really cool. We had a really talented REDCap programmer who helped us create this tool. One of the things too is that they felt like the tool forced them to articulate all of their strategies. And this was a really good thing for me to hear, because one of the motivating factors of creating this is that we know people don't report all their strategies. They report the strategies that they think are most relevant or the ones that they introduce as part of sort of their like independent variable within an experimental research project. But they often ignore a lot of other strategies that actually were used either by the system or were just not kind of like the main focus. And so this was really a way to get much more transparent, much more comprehensive. And the research centers actually liked that fact that they were forced to articulate all of them. Some things that the users found difficult, didn't like. They said this was not necessarily that like didn't like, but they noted that using this requires knowledge of implementation science terminology, specifically the ERIC compilation, as well as the CFER, determinants of practice. It also requires some knowledge of conceptual models because you are conceptually or theoretically having to say why you're using the strategy that you are. So this actually gets into Allison's question a little bit. So understanding the strategy definitions, we did not ask implementers to do that at all. That was done at a centralized level with implementation scientists as part of the primary team that met to do the strategy specification. What we asked is, what are you doing? And then we translated that into the ERIC strategies. In that way, it really just kind of fell on the research team to have that knowledge, and we didn't ask the implementers to do it. The other thing is the implementers don't ever touch the tool. They don't enter data. It all goes through a central team, and part of that is because it requires this knowledge. One thing that was recommended too is that it may need to have some kind of updating for multi-site, multi-center projects. That would allow for maybe health center specific REDCap entry forms that then get centralized. And so kind of like another extra level of what we currently have, which is basically all the units within one study get reported into one REDCap form. But potentially if there's multiple centers or multiple sites, you'd want to have a REDCap for each site and then have a process for actually combining and synthesizing those kind of at the end. So that was a recommendation, is that we consider what kinds of modifications would be needed to the REDCap tool or to the procedures to better accommodate multi-site, multi-center projects. There was a question from, and admittedly this happened from one of the centers, was they were unclear the value of the level of granularity that was requested. And I will mention that this was in part like the amount of time and like who was involved, that kind of a thing. One of the things that we actually envisioned this tool to be able to facilitate is time-based activity-driven costing approaches. So with the exception of people's salaries, the list tool has the dimensions for time-based activity-driven costing approaches. So you can turn this into budget impact analysis, cost effectiveness analysis, et cetera, really easily. And so not having to do that in a separate platform or a separate place could actually reduce burden and reduce the amount of time needed and number of resources. But it does, again, for people who are not doing that, it does have a level of granularity that might seem like, I'm not sure we're going to make use of this data. But again, that was only from one of the 3 research centers. So take that for what it is. And the what are you doing question to implementers did not follow a particular systematic approach. So yes, it did. We asked them, what are you doing from an implementation strategy perspective? When they gave us a strategy, we would go through all of the specification. So we would say, who does that? When do they do it? What's the indication? How long does it take? All those pieces. So just some conclusions and next steps. Oh yeah, and so the other part of your question, Bianca, is did they just describe what they did as they felt appropriate? No. So we did actually use the ERIC strategy compilation to trigger their memories as well, or to jog their memories about things that were being used. So conclusion, so the list tool and process does represent an advancement in characterizing dynamic features of strategy change over time. It does help us enable more precise specification of the additions, modifications, adaptations, discontinuations of strategies within and between studies, which is really a critical element of the science that has been kind of thwarted in the past by people using different kinds of methods, not having complete information, all those kind of fun things. it continually came up that knowledge and familiarity with implementation science theory as well as terminology is necessary to use this. I don't know how to get away from that. I'm not sure that we'd want to get away from that completely, but it does require that someone on the study team is able to really translate into the CFR, ERIC, et cetera, within the tool. We really do need some future research to evaluate the validity of the tool and its generalizability across diverse implementation contexts and innovations. That is being done. There are a number of studies that have picked up this tool since we've made it available. And so data on this kind of external validity and generalizability will be forthcoming. Not quite there yet. I do want to acknowledge that this was funded by and took place within the IMPACT Consortium. This is a National Cancer Institute funded under the Cancer Moonshot. This is a complete list of authors who contributed to this work, and a manuscript is forthcoming. Not quite ready for submission yet, but we are getting close. And then here are just the kind of complete membership of the IMPACT Consortium that I'm required to share whenever we present this data. Here's some selected references for folks, and again, I'll make the slide deck available. And that's all. If anybody has additional follow-ups or anything, go ahead and send me an email. When we distribute the slides and everything else, I will make sure that the link to the list tool in GitHub is made available as well for anyone who might want to download that and make it available in their university's REDCap instance. So I don't think there's any lingering questions in the Q&A that I haven't done, but please add additional questions, thoughts, etc., that you'd like me to chat about here. I don't know if people are allowed to take themselves off mute and have a conversation in the way that we have this set up, but that's also possible if we have that capability.
Yes, so we do have some time left for questions. If you guys do want to unmute yourselves, I believe you would have to raise your hand and then I could go ahead and unmute you.
Thank you, Eduardo. Can you hear me?
Yep, we can.
Okay, excellent. This is Bianca again. So thank you. Fascinating presentation, Justin. Were you surprised by the fact that when you documented strategies that the adapting and tailoring strategies to context wasn't more present in what happened across sites?
Yes and no. I mean, I think just the actual context of two of the research centers kind of mentioned this. They were done within one healthcare system each. And so I think that the prospective plan already basically selected strategies that were context relevant and aligned with their needs. And neither of those projects had prospectively planned to continue to adapt and tailor those strategies. It wasn't that it was against their protocol, but it wasn't like an optimization design where you're intentionally changing things over time to adjust to the context. So it really depends on the, not to overuse the word context, but it does really depend on the context of the study itself about whether or not that would be expected or not. I think not surprisingly, the other research center that had multiple healthcare systems had much more discontinuations, additions, and adaptations. And partially because they proposed an implementation strategy that they thought was generalizable across 6, healthcare systems, but in reality wasn't. And that's totally expected, and that was part of their research question, is how much of this is generalizable. So in that particular, those auspices just create a more likelihood of having more adaptations and changes.
Thank you.
How do you think lists should be used for meta strategies? Great question, Elizabeth. I did not actually address this appropriately. The guidance is to break it down to the discrete strategy level. So even within practice facilitation, which is an awesome example, there's 5 or 6 discrete strategies that are usually part of practice facilitation protocols. So you'd actually want to break those things down into training and, kind of the other pieces that they might be doing. When you actually go ahead on the back end and choose how to report the strategies and how you might want to chunk them, that would be totally appropriate to look at the actor, right? So the practice facilitator is going to be the shared actor across those implementation strategies. And so that would allow you to basically say practice facilitators did X amount of time, et cetera, and whatever, however you want to slice and dice that across these different implementation strategies that we call practice facilitation. This would also apply to something like getting to outcomes or another protocolized multi-component implementation strategy where you can't track that at a meta level. Like you have to track that in the individual components for various reasons. But the tool would really make that much more easy to do. Hopefully that answers your question. If not, please raise hand or put another in the Q&A. So Claire asks, would you be able to pilot the use of the tool and or components of the tool? We're tracking adaptations to intervention components, not necessarily strategies, but the process you outlined should work well. Yeah, you can pilot the use of the tool. You just need to actually put it in REDCap and do that. Honestly, I would just take a look at the requirements and think about whether it's worth it for your particular project. We're trying to work on sort of indications and contraindications for use of lists. There's very few contraindications, but there are certainly kind of study types or research questions that are more aligned with what lists is asking you to collect in terms of strategy use and modifications. But yeah, it really is kind of a thought about whether or not it applies to your project and your research questions. Annette, can you get reports with timelines on the various strategies used and stopped? Yes. So the backend database for lists is kind of interesting. So it basically ends up looking like every line is a discrete strategy. Anytime that a strategy modification is made, you get stacked data entries. So because you're not entering data every single time, it's not going to look like a typical survey. It's going to look more like a relational database or something like that, where, like, let's say I'm doing audit and feedback procedures, but I keep changing it. It has like 7 changes over the course of the project. You're going to get audit and feedback as line 1. The next 7 lines on audit and feedback are going to be all the times that you change something. It doesn't indicate in the data set what changed. You'll have to actually look at that yourself, but you'll be able to compare to the previous entry, oh, we changed the person who does this, or, oh, we changed the study units that are using this, and it was discontinued in others. So in that way, you can actually, again, that's kind of the dynamic relational nature of this data, is you'll be able to see exactly what happened. In terms of the timelines, you could probably pretty easily extract or just sort by when the strategy started and then a strategy stop date, and then maybe come up with a cool figure for actually showing, like, timeline wise, here's when our primary strategies were used and when they were stopped, changed, etc. That would be pretty easy to do. It would require some kind of data visualization software, I would think, or just a creation of a figure. The tool itself doesn't have that capability right now. I don't even know if REDCap has that capability, honestly. Any other questions, reflections, thoughts? I will say that this approach is again kind of going into the indications. 2 places that really makes a lot of sense to use this would be implementation trial designs where equipoise is really critical. So a head-to-head implementation trial where you have 2 different implementation strategies and you want to see which one is better, or you have a non-equivalence or non-inferiority design, you want to make sure that you're able to explain from a strategy perspective what actually led to the differences between those two different conditions or arms in your study. And so the list tool can really help get into the granularity of that particular question. The other place would be optimization designs. So if you are trying to kind of optimize, tailor, arrive at the best implementation strategy, being able to track and show how the strategy was modified over time and what, potentially at different sequences, if you're actually looking at, quarterly or yearly outcome data, and then you make changes based on what you see, you'd want to be able to show some kind of a link between the changes made to the strategies and the outcomes that are then associated with that change. And this would help really get at that detail that's needed to demonstrate that without just saying, we think it was this that led to this change. So those are two really important ones. The other place that's important is, I mentioned that the step wedge design earlier, or like a rollout design. If your design really does either hinge upon having things be equivalent, or when they're not equivalent, being able to understand exactly why, having really good detailed information about the strategies being used and being able to compare them to the other study units, either to demonstrate that they were similar, or if one particular cluster maybe was completely ineffective, maybe you could actually demonstrate that it was because they weren't doing certain aspects of the implementation strategies that they should have been. So it really does help explain and interpret the findings of multiple kinds of different trial designs. I have about 6 minutes left. If there's no other questions, we can end early, but if anyone has questions, please post or raise hand and feel free to ask. I don't know if the chat is going to let me drop the GitHub link for everybody, but I might as well do that in case anyone's interested. Yep, it did. Great. Thank you, Jenny. Guessing that means we're wrapping up. Let's give everyone 5 minutes before their next meeting. I know we all probably have some level of Zoom fatigue. Thank you all for attending. And yeah, please reach out if there's any additional questions. And the slides will be available pretty soon.
Thank you so much, Dr. Smith, for your time today. And thank you everyone for attending.